Thank you, Professor Majdi, for these two excellent lectures, and we apologize for the interruption due to some technical problem. And now coming to the last lecture in this session, which will be presented by Dr. Mohammed Alomair. Dr. Mohammed Alomair, he is known to most of you, maybe all of you also. He's a consultant rheumatologist, associate professor at King Saud University, and he got 2 subspecialty in rheumatoid arthritis, systemic sclerosis from University of Toronto. He held the task force to establish a specialized clinic at King Saud University Medical City, where he is running both RA and scleroderma clinic, and he is the founding and the president of the Charitable Association of Rheumatic Disease. Dr. Alomair, he published more than 44 peer-reviewed articles and book chapter, and he's going to talk about the childbearing in systemic sclerosis and overview. So welcome, Dr. Alomair.
بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. السلام عليكم ورحمة الله وبركاته. I would like really to thank the audience for staying with us in the third day. I was expecting a smaller number. So my talk was actually a very challenging talk. And the literature review of this talk again is different than when you look at randomized controlled trials and large registries. And finally, I'm gonna talk about many aspects. So I hope that you're gonna enjoy with me exploring this part of the scleroderma life of patients that we usually do not discuss. Okay. This will be my agenda. Excuse me? Okay, so basically systemic sclerosis is a complex disease. It has many pathogenic mechanistic pathways that are involved in the development of the disease, the severity of organ involvement, and the long-term outcomes. As rheumatologists, whenever you see a scleroderma patient, you always have to have this kind of organ-specific assessment and organ-specific management. Now I'm gonna just talk about, in general, how patients with scleroderma come to me in the clinic. So some of them, they usually come in a young age, they are single, and they start to develop the disease and have the physical distortion and manifestations in the skin and the joints. The other group of patients who are actually have been already married, and then they develop the disease and they already have established a family. And again, the most challenging are the patients who are in the middle, who are actually being engaged or in the first years of their marriage, and then they develop the disease. So it's important to really have this kind of exploration of the private life of these patients. And for me as a male rheumatologist, it's difficult to talk about intimacy with female patients. And sometimes I ask my colleagues, either my fellows or the multidisciplinary team, to have this kind of discussion with patients. And believe it or not, some patients, they actually go up front and talk to me about their problems. So again, sexual life is very important in all patients, especially patients with chronic disease. And there are many aspects where the face is a problem, and the hyper and hyperpigmentation, which is actually the most horrible feature of scleroderma skin involvement, because there is no treatment, is very clear, and it looks actually worse than vitiligo. Okay. So physical changes are associated with a negative impact on female sexuality and functioning. Multi-organ involvement may limit fitness during the intimate relation. The skin tightness around the genital tract and joint contraction of the hips makes it a problem. And when I was a fellow, I always was taught that scleroderma usually spares the genital areas and the breast. And actually, this is not true, because if you examine patients, you're gonna find some kind of involvement. Hand pain, digital ulcers are also a problem in these patients, especially the continuous hand pain due to ischemia. And of course, the physical appearance makes patients insecure and need more support from the partner. I'm going to take you on few studies. There are many studies that I have not included because of the time, but now it's a more explored part of the scleroderma research. This is a Turkish study looking at 30 patients, and they found that 86% of them had some kind of sexual dysfunction. In the large table up, you can see significant p-values. In the two tables down, it tells you that it doesn't matter what kind of disease the patient has limited disease, diffuse disease, has ILD, no ILD, it doesn't make a difference. Just having the disease will increase the risk of having sexual dysfunction. This is another study which colleagues from the UK and from Canada have combined their data, and then they found sex and age matched patients from the general population from UK, and they found a significant increase in the risk of having sexual dysfunction on all aspects. طبعا FCFI is female sexual function index, which has many components: desire, arousal, lubrication, orgasm, and pain. This is actually the only study from the Arab world looking at female sexual dysfunction in Tunisia, and really colleagues from the far western Arab countries like Morocco, Tunisia, have looked at sexual dysfunction in many disease areas. So if you're interested to look at data, maybe Egypt and Morocco has the most publications on RA, lupus, spondyloarthritis. And in this particular study, despite of the small sample size, you can see significant p-values, and also that sexual dysfunction correlates with quality of life and the HADS, which looks at anxiety and depression. Now, one of the possible causes of female sexual dysfunction is the vasculopathy they have. So clitoral blood flow is affected because of the increased vascular resistance. This is a small study from the UK where they have shown that when you do a Doppler on the clitoral blood vessels, you see increased vascular resistance, and it correlates with the female sexual function index components. Now, moving to fertility, reported rates of early pregnancy loss, especially from the United States large registries, the Pittsburgh registry, has been ranging between 14 to 15%. There are many problems. It's not only being pregnant, but also keeping the baby. Preterm delivery rates have ranged between 8 to 40% along the literature. If we look at ovarian preservation, cyclophosphamide is a very important drug in managing scleroderma-related ILD, but also treating skin disease that is refractory to many components. We use cyclophosphamide. In our institution, we have a protocol of using leuprolide. I'm sure many of you use leuprolide. It's a wonderful drug. It's very easy to use, And actually, one of the fellows was talking to me about why you are not following exactly the protocol. You're not giving the leuprolide 10 days prior to the cyclophosphamide dose. And I was just telling him that the concept is preservation of the ovaries, that you want to take the ovaries into a dormant stage where you can preserve the ovaries, so the patient, whenever she wants to conceive, she conceives. Now, with the advancement of therapy, not too much like in RA, but we have many other options. So any scleroderma patient that is young, in a childbearing age, I would really put cyclophosphamide really low on the list. I would use mycophenolate mofetil if a patient has ILD. I would use methotrexate for skin disease if the patient does not have ILD, and tocilizumab or nintedanib for patients who have ILD. Now, the literature on cyclophosphamide-induced gonadal toxicity is a mixed literature between oncology and rheumatology. So whenever you look at numbers, please make sure what you're looking at. Are you looking at a mixed population or looking at a mainly lupus population? And there is a beautiful study. I think I have the, no, it's not here. There is a beautiful study by a scleroderma expert called Peter Merkel, who has looked at the cumulative dose of cyclophosphamide that actually can induce gonadal toxicity or is associated with increased gonadal toxicity based on the age group, which is about 6 grams. So oral cyclophosphamide is actually associated with a very high cumulative dose and more risk of gonadal toxicity. And this is the plot of different studies looking at the relative risk of ovarian preservation. And actually, many patients have amenorrhea, have some infertility or subfertility. Once you wait for a while, then they go back to a better level of fertility and get pregnant. This is a study, a beautiful study done from colleagues from Thailand. Thailand is actually one of the best countries who have registries in rheumatic diseases. They have looked at patients with scleroderma who actually got pregnant before getting the disease and after getting the disease. And this is actually maybe the only study who has looked at this aspect. And you can see the maternal and fetal outcomes in the dark green. Is this dark green? Turquoise, I mean. Which is after the disease, and in the light green before the disease. You can see a statistically significant increase on many complications when a patient has developed the disease. So the patient is his own control or her own control. This is, again, a really amazing study despite of the small number in the group after having the disease. And here they are comparing their data to other registries like the Italian cohort. The IMPRESS is a new registry that is ongoing, and they are collecting patients. We assume that in the next 4 or 5 years, you're going to have data on that. The Brazilian registry, which is a very famous one. And then they also compared it on your right-hand side on diseases or other rare diseases like myocyte cohort or the Takayasu in India. Now, APS is a very important antibody in connective tissue disease, especially in lupus, which might explain a lot of the miscarriages and the pregnancy-related morbidity. But in systemic sclerosis, the prevalence of autoantibodies is very limited. So here you could see on this side, the prevalence of APS antibodies is very small, but in a cohort of about 250 patients. But again, it has been associated with an odds ratio that increased the risk of vascular and pregnancy-related comorbidities. And this is, again, a review of the literature, and you can see that the rate of having APS positive in systemic sclerosis is very small. Now let's go to another possible problem, is inflammation of the placenta. So this is a nice histological study where they have evaluated the placenta of patients with systemic sclerosis, patients with other rheumatic diseases, and control patients. And they found that there was some inflammatory cells, especially CD68 cells, that have been increased, causing villitis in the placenta. And they also found that the level of CCL5, which is an important chemokine in systemic sclerosis, is associated with the increased risk of having villitis. So also inflammatory component in the placenta might play a role in pregnancy-related morbidity and complication. This is a nice graph looking at vasculopathy component. This review is actually a beautiful review because it shows you the narrow view on vasculopathy in systemic sclerosis, which is Raynaud's phenomena, pulmonary arterial hypertension, and renal crisis, and then the wide view where vasculopathy actually plays a role on all manifestations, including reflux or GI dysmotility, on calcinosis, and many other aspects. If we look at Raynaud's phenomena, it's actually one of the few things that improve during pregnancy, and we can safely reduce vasodilators in these patients once they feel well because of the progesterone effect on the vascular bed and the increased cardiac input. Renal crisis has been always feared as a risk factor in patients with systemic sclerosis, and the main reason is the activation of the renin-angiotensin-aldosterone pathway, or the increased activation in pregnancy, which is the main pathogenic pathway in renal crisis. So, in a practical way, when a patient has diffuse systemic sclerosis, in the first 3 years, this was the maximum risk of having renal crisis. I usually advise my patients not to get pregnant in the first 3 years, if they ask me, of course, because this is the time where we're using a lot of medications that are not safe during pregnancy, and because of the potential risk of having renal crisis. Unfortunately, in our center, we do not have the RNA polymerase III antibody, which could be also an excellent biomarker to evaluate the risk of having renal crisis in these patients. Now, in one of the largest studies, which was published a long time ago by Dr. Virginie Steen, you know her, she's the mother of scleroderma around the world, in 70 patients, they have found that actually renal crisis does not occur early on. It actually occurs later on in the third trimester. And once renal crisis occur, okay, it's like eclampsia. You have to deliver the baby, the mother is more important. So renal crisis is an emergency in normal patients, and it's even a more serious emergency in a pregnant lady. pH is one of the things that I like to put a station for fellows, because whenever we talk about pH in pregnancy, it's one of the hardest decisions for me as a rheumatologist when I discuss with my female patients. If you look at the pH literature in general, maybe Dr. Majdi, who is proudly our pH expert in Saudi Arabia, can discuss that in the larger pH population. pH is a no to go in a patient who wants to get pregnant, because the rate of mortality in pH patients is extremely high if they get pregnant. So it's like almost a 50% risk of death or progression in a patient who has established a moderate to severe pH when they get pregnant. So if a patient gets pregnant, for example, unplanned pregnancy, one of the most important options you have to discuss with patients is therapeutic abortion. And these patients will actually advise for tubal ligation. So this is a very important point, because patients or female patients might have a very difficult emotional time accepting that they will not bear a baby. And for the time being, till we have more effective therapies that control pH, you should advise against pregnancy in a pH patient. In the patient who has a severe, moderate to severe pH gets pregnant, you would advise for therapeutic abortion. And you could see from this scheme the many pathways and problems that these patients will face. The woman's body go into different physiological changes to handle the pregnancy. And patients with PH do not have the adequate reserve to go into these changes, especially if she is in an older age. Now, reflux, despite that hypothetically, reflux is a very common and challenging complication in patients with systemic sclerosis. From the experience that I have, I will be happy to discuss it in the Q&A session. Patients who got pregnant in my clinic did not have any problems with the reflux. I was really happy because, you know, ranitidine now has a black box, and we're having problem having ranitidine. And maybe PPI will cause also subcutaneous lupus. For I don't know what kind of gastroprotective medication we're going to have in the future. But what I really usually advise my colleagues, my patients on who have reflux, is that you have to focus on lifestyle modification pretty much. This would be the main thing to improve your symptoms and make the pregnancy go smoothly. Skin, ILD, cardiomyopathy, we do not have data, but we believe that they do not really change during pregnancy, but you have always to observe these patients and involve multidisciplinary team. This is one of the most important papers that have been published in rheumatology in the last maybe 3 or 4 years. And I advise each one of you to have it and to establish some kind of protocol or pathway in your clinic, including this. So this is general in rheumatic diseases, not in scleroderma, lupus, RA. It includes all medications. And just by showing you this 2 slides or 2 tables, is that patient with systemic sclerosis options are almost all of them are not approved to be used in pregnancy or are not safe in pregnancy. And, of course, steroids, it's not a major player, but rituximab, cyclophosphamide, methotrexate, MMF, and now we have tocilizumab and nintedanib. They are all not safe in pregnancy. So it's a very important challenge when you want to manage patients who actually get unplanned pregnancy or are planning with you the pregnancy. And actually, I have 2 patients. One had a planned pregnancy and one had unplanned pregnancy. We can discuss later on. Now, this is my personal view. There is no reference, so we can freely discuss this. So, improving management and prognosis of a serious disease means to enable the patient to lead a more normal life. And I always try to give hope to my patients whenever there is a space of hope. And childbearing is a very important aspect of life in every woman. So a very long discussion and a good engagement between the patient and the physician is important to reach the best outcome. It's of course a challenge to manage these patients and should be in a more specialized center. The personal values and beliefs should be respected by the treating clinician. And we have to know how big is the wish of the woman for getting pregnant. Is it really forced by the family, forced by the husband or by the community, or is it really the patient? And what kind of risk the patient is willing to take to have a baby? Now we have about 6 pregnancies in our cohort. We're waiting till we have a larger number to publish that. We're also trying to run a qualitative and a quantitative research on sexual dysfunction in patients with systemic sclerosis, which inshallah we're going to start it in the next maybe 6 weeks with our colleagues who have qualitative research expertise. We're welcoming any colleagues who have patients and who would like to participate in our project. So in conclusion, there are many challenges facing the scleroderma women who are trying to have a normal sexual and reproductive life. The literature, as you have seen, has very small number. You cannot take solid conclusions, so you have to treat really case by case in these patients. There are many ethical issues that we need to discuss with our patients. And with this, I would like to conclude and thank you for your attention.